Sarah, this is Rich. Do you happen to have a cell number for Dr. Moss?
It looks like we have a quorum. He's joined.
Oh, good. Great. We're ready to go.
Good. Yeah. Thank you. There you are, Mike. Welcome. Okay, Sarah, I don't have the welcome slides. Are you just going to scroll through those?
Yeah, I'm going to present them. Can everyone see them? My screen?
Yes, we can see
Okay.
your screen.
Yeah, I'll go ahead. Are you ready for them?
Yeah. Well, welcome, everyone. Welcome to July's meeting. We'll get started. I'll read the welcome slides and we'll get going. This meeting is being held virtually and is hosted by the Utah Department of Health and Human Services, Center for Medical Cannabis based in Salt Lake City, Utah. Public notice of this meeting is provided and as required under Utah's open meeting laws, and it was posted on the Utah Public Notice website. Yay, live recording. In compliance with Utah's open meetings law, this meeting is being recorded. A recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. Written minutes will also be provided. And approved minutes will be posted to the Utah Public Notice website no later than 3 business days after board of approval. There we are, board members, myself, Matt McKiff, Jennifer Norris, Michael Moss, Misty Smith, and staff. I don't know if I want to read everybody, but there they are listed. Okay. Public comment will occur at the conclusion of the scheduled agenda. Comments will be limited 2 minutes per person, and we will take comments one right after the other. As a courtesy to everyone participating in the meeting at this time, I will request that you place yourself on mute unless you are speaking to the group. Board motions and votes will be recorded in the minutes. We'll now turn our attention to the agenda. This proves that I can read. Okay, so the May minutes, do we have the minutes from May, and were they, I don't remember seeing them, so we could review them now, I guess.
One minute, please. I'm sorry. I don't have those available just offhand. I apologize.
That is fine. That is fine. When you're driving, you're on the spot, so that's okay. We understand. I was trying to find the May minutes to review them beforehand, but I couldn't find them. So as soon as we get them, we can.
Yeah, this might take a minute. We've had some reorganization of our shared drive, so I will continue to hunt those down. I'm sorry. Can we maybe skip that and come back to it? I apologize.
Sure, that's okay. So during our last meeting, we discussed changing governance of the board. We've discussed it on previous occasions, but I don't know that we actually did a vote and a nomination and a vote. But what we had discussed previously is when Katie was served. Is Katie on today?
No, she's not on.
I don't see Katie. Anyway, during the last year, Katie was nominated as board chair, and I was going to serve as vice chair to sort of prep for this next year. And so we had discussed that, and I've been serving as vice chair, meeting with Katie and with with the team and in preparation. So we now need to nominate and vote on chairmanship for this next year. And then at the previous meetings, we also discussed, Mike, if you would serve as vice chair for this year in preparation for the governance for next year. So if everyone is in agreement with that, we'll go ahead and call for nominations. Go ahead, Sarah.
I was just gonna ask if we had a motion.
Yeah. So we'll call for nominations or motions to nominate for chair and vice chair for this year.
Do we need a motion to do the nominations or a motion to nominate Matt as chair?
Just motions for nominations. I think I think we
Correct.
all need to
I'll
nominate.
move to make nominations for chair and vice chair.
Okay, we have a second by Misty. Any discussion? I see no discussion, so we'll all vote for opening nominations, I guess. Everybody raise your hand or say aye.
Aye.
Great, we now have a motion passed to accept nominations. So we now may make nominations.
I nominate Matt McKipp for chair of CRRB.
Thank you. Do we have a second?
I'll second that.
Great, thank you, Jennifer. Any discussion? Okay, well, now then we'll move to a vote. All in favor to pass the motion to nominate myself as chair for this next year. I'll raise your hand or say aye.
Aye.
Any opposed? Great, looks like the nomination passes. Thank you so much. This is all very official. So I will now open up nominations for vice chair. And since I can do that, I would nominate Mike Moss to be a vice chair.
I'll second that.
Misty second. Excellent. Thank you. Any discussion? I see no hands raised for discussion.
I'll just say, I know I have not been on the board as long as some others, but I'll be happy to help out.
You have expertise that we can all, we all appreciate. So I think it'd be great.
Yep, Mike, I think you're excellent. So I really think this is really good. And so we're gonna, yeah, your contributions thus far has been phenomenal. And due to the limitations on service on the board, none of us have been here for really that long. It's really meant to turn over frequently, I think by design. So even where I am, I don't feel like I've been here very long. Anyway, okay, well, if there's not any more discussion, welcome, Lauren. We'll move to a vote. All in favor for Mike Moss serving as vice chair for this year, please signify, raise hand or say aye. Excellent. Any opposed? All right, thank you. Looks like the motion passes and those will be recorded in the minutes for today. I hope someone's taking minutes.
Yes, and it's all recorded too. I just want to say, I'm sorry, we cannot find the meeting minutes from last meeting, but we might have to look for them later. There's been a kind of an overhaul of our drive and it's not in the usual place. So unfortunately, we might have to do double approvals next month or next time we meet, if that's all right.
Sounds good. We'll have to do
Okay.
it. The next,
Okay, thank you.
let it be recorded in the minutes that we'll have to record, approve May minutes at our next meeting. Okay, now that our business is out of the way, and welcome everyone. I didn't do a really warm welcome, I guess, but welcome everyone who's visiting to this meeting. We hope to make these informative and well, they're working meetings, right? So sometimes they can be quite detailed, but welcome, and we would like to get started. So Lauren has written an amazing document on multiple sclerosis. So the topic of today is reviewing multiple sclerosis and evidence-based guidelines for the use of cannabinoid treatments for multiple sclerosis and its many side effects. I really like how it was broken down into different side effects. And then we will discuss if we should make any changes to our evidence-based guidelines posted on our department website. So without further ado, Lauren, if you're ready, you can take the stage and go ahead with our review.
All right, sounds great. Let me hopefully I'll be able to share my slides here.
I made you a co-host, I hope. Okay. you got it.
Okay, you can see them. Perfect. All right, so hi everyone. My name's Lauren and I'm a pharmacist working with the Center for Medical Cannabis. Matt already introduced what we're going to be talking about today, so I'll just keep going along. As he mentioned, the purpose of this brief review was to summarize evidence about cannabis or cannabinoids, which I'll refer to as CBPs, for MS treatment to assist the board with updating their guidance document. I followed a hierarchy of evidence approach, meaning that I searched for systematic reviews of randomized controlled trials first, and then I supplemented that search with lower levels of evidence as appropriate. A recent systematic review and meta-analysis by Filippini et al. Formed the focus of my review, since it's well conducted and comprehensive. I also searched for other systematic reviews, abbreviated SRs or RCTs, published after Filippini et al.'s literature search, and included publications that address people with MS receiving any CBP for any duration. I focused on RCT evidence when available, but I also addressed some observational study data that was included by the SRs, particularly for safety outcomes. The SR by Filippini et al. Focused on RCT evidence for symptomatic treatment of MS with cannabis or any cannabinoid in adults with any type of MS. Authors prioritized patient-reported efficacy or safety outcomes, and I focused on the results for these outcomes or primary outcomes of studies from my supplemental search. Filippini et al. Found 25 RCTs with sample sizes between 14 and 657 people meeting their criteria. Most RCTs were for a short duration, with only 2 being for longer than 6 months. Most studies allowed patients with any type of MS, and the age range of patients included in the trials was between 18 and 60 years old. Female patients predominated most trials, which is characteristic of the demographics of people with MS. Slightly over half the trials studied nabiximols or Sativex, an oral mucosal spray available in other countries consisting of a 1-to-1 ratio of THC to CBD extracted from the cannabis plant. Oral synthetic THC analogs such as nabilone or dronabinol were the next most frequently studied cannabinoid. Inhaled cannabis was studied in only 1 trial. I did not find any recent RCTs in my supplemental search. I did find 9 other systematic reviews published since the Filippini et al. Review. You can refer to Appendix A of the report for details about those reviews. In general, other reviews were less comprehensive in terms of the outcomes or treatments assessed compared to Filippini et al. And many, in my subjective opinion, have some quality concerns. Evidence from the other systematic reviews is nonetheless presented to supplement or contrast findings from that main review by Filippini et al. So over the next few slides, I'll summarize main results from Filippini et al. And other SRs as applicable. Meta-analysis results from Filippini et al. Are shown in the table at the top of the slide, including the outcome assessed in the first column, the number of RCTs and participants in the second column, and results in the right column. Most RCTs for management of MS evaluated nabiximols or oral cannabis extract, known as Canador, as add-on therapies for patients with moderate to severe spasticity. By meta-analysis, Filippini et al. Showed that short-term treatment with nabiximols or Canador significantly increases the odds of reporting reduced spasticity by at least 30% and significantly improves mean spasticity compared to placebo. There was evidence of moderate to substantial heterogeneity, and the certainty of evidence was rated as moderate using the grade system. Other SRs agreed with Filippini et al. The main maintenance nabiximols dose was about 10 to 23 milligrams of THC and 10 to 21 milligrams of CBD. One SR concluded that reduced spasticity with cannabis-based products may be maintained for at least 12 months based on observational data. Only one small RCT comparing dronabinol to placebo reported on the clinically significant outcome of achieving a pain reduction by 50%, finding benefit favoring dronabinol. Meta-analysis from 8 RCTs showed modest improvements in mean change in pain for oral cannabinoids versus placebo. Filippini et al. Rated the certainty of evidence as very low or low, reflecting very little or little confidence in the accuracy of the result. Pain was briefly mentioned by one other SR, but that SR only included evidence from one RCT, which did not demonstrate significant, or which did, sorry, demonstrate significantly reduced pain intensity with nabiximols. Filippini et al. Included one small crossover trial that failed to show tremor improvement from oral Canidor over placebo after 2 weeks of treatment. This trial is considered to have a high risk of bias. Another SR included 4 trials of nabiximols and Canidor, reporting a tremor outcome that did not find a benefit after short-term treatment, but a significant reduction in patient-reported tremor was observed with Canidor versus placebo at 1-year follow-up, and authors concluded the evidence for cannabinoids or cannabis to treat MS-related tremor is inconclusive. 2 RCTs demonstrated benefits from cannabinoid-based treatments compared to placebo for some symptoms of overactive bladder. The first trial failed to demonstrate that 8 weeks of add-on therapy with nabiximols for overactive bladder symptoms among adults who failed first-line treatments was not superior to placebo for the primary outcome of number of daily incontinence episodes. However, nabiximols was superior to placebo for secondary outcomes of the number of nighttime urination episodes and number of daily voids. The second trial that evaluated either oral THC or oral cannabis extract for urge incontinence demonstrated statistically significant reductions in the frequency of patient-reported urge incontinence episodes compared to placebo. However, a difference compared to placebo in that trial was not demonstrated for any domain of the King's Health Questionnaire, which is a validated patient-reported health questionnaire for bladder-specific health-related quality of life. Both trials were rated as having some concerns for one or more risk of bias domains. Filippini et al. Assessed the patient's global impression of change, or PGIC, and health-related quality of life by meta-analysis from using results of 8 RCTs of various cannabinoids compared to placebo. Cannabinoids probably increased the number of people reporting very much or much improvement in overall health status based on moderate quality of evidence, but little to no differences in mean health-related quality of life scores from baseline were observed based on low quality of evidence. Filippini et al. Examined cognitive adverse effects as a composite outcome with other neurologic effects such as dizziness or headache, finding low certainty evidence of an increased odds of having at least one of these events when taking a cannabinoid product versus placebo. 4 other recent RCTs focused on cognitive adverse effects, primarily examining the impact of cannabinoids on patient performance on neuropsychological tests of different cognitive domains. 2 SRs narrowly focused on nabiximols RCTs or observational studies, and overall, these SRs reported that impaired cognition with nabiximols is rare, and there's probably minimal risk for increased cognitive adverse effects when the nabiximols are used at the recommended doses for up to 12 months of treatment. However, evidence was rated as low or very low certainty. The 2 other SRs assessed cognitive domains from experimental or observational studies with any type of cannabis or cannabinoid exposure. Notably, some of the observational studies included patients with MS reporting recreational cannabis use. Results were mixed, with some studies showing impaired cognition on neuropsychological tests. The most consistent association was impaired attention and working memory, especially with whole plant cannabis use. Due to high heterogeneity and lack of reported details in the studies about the cannabis type, dosage form, dose and duration of use, evidence about the increased risk for cognitive impairment with cannabis is inconclusive. Long-term follow-up data was limited, especially for studies of non-whole plant cannabis such as nabiximols. SR authors Landrigan et al. Concluded that cognition may be differentially impacted in people with MS depending on the type of product, the duration of use, and the indication. Filippini et al. Found that cannabinoid-based products may increase the number of patients who withdraw from trials due to adverse events and nervous system adverse events compared to placebo based on low certainty evidence. Taking cannabinoid-based products might slightly increase the odds of serious adverse events compared to placebo. However, this result was not statistically significant and it was based on low certainty evidence. Although general adverse events were not systematically addressed by other SRs, when described, the cannabinoid-associated adverse events in clinical trials were events known to be associated with cannabinoids that we've seen come up in other meetings, such as somnolence or dizziness, and usually were mild to moderate in severity. So in summary, based on evidence from recent systematic reviews, clinical evidence for the treatment of MS with cannabis-based products is limited to symptomatic treatment. Few studies considered whole plant cannabis, with most efficacy trials evaluating oral mucosally administered nabiximols or oral synthetic cannabinoids. There is moderate certainty evidence from RCTs that cannabinoid-based products improve short-term spasticity as add-on therapy and increase the number of patients reporting significant improvements on the patient's global symptom rating in people with MS. Based on low or very low certainty evidence, cannabinoids might improve chronic neuropathic pain and increase the odds of nervous system adverse events and withdrawal from trials due to adverse events in people with MS. Short-term treatment with nabiximols might improve some overactive bladder symptoms in patients with MS. There is inconclusive evidence for the effect of cannabinoids on tremor and cognition in adults with MS. Filippini et al. Concluded that cannabis-based products, particularly nabiximols, might be helpful for treatment of moderate to severe spasticity symptoms that are insufficiently managed with other treatment options. Filippini et al. Were uncertain about the applicability of the evidence from their review to all people with MS with spasticity or chronic pain and people who are cannabis treatment naive. Co-treatment with other therapies during trial follow-up potentially confounded some of the results, and the limited long-term data are limitations of the available randomized trial evidence from Filippini et al.'s review. So this was sent out to the board after the fact. I didn't include this in the report that was sent out, but when I was putting together the presentation slides, I came across this guideline from the American Academy of Neurology, which was first published in 2014, but they did reaffirm it in February 2023. This was sent out to the board, and I just summarize it on the next few slides. I find that their conclusions largely agree, with the systematic reviews that I just talked about, but I'll try to just quickly go through their findings. So the AAN concluded that oral cannabis extract is effective for spasticity and pain symptoms not due to central neuropathic pain. So clinicians might consider offering this treatment to people with MS with those symptoms. However, the AAN advised caution in extrapolating evidence from the standardized oral cannabis extracts used in these studies to non-standardized cannabis extracts. Oral cannabis extract is probably ineffective for tremor and spasticity signs, and evidence for treatment of bladder symptoms was insufficient for conclusions. There was insufficient evidence to evaluate outcomes with smoked cannabis. Evidence for synthetic THC is like what they found for oral cannabis extract with a slightly lower level of evidence. So the AAN concluded tongue twisters. Clinicians might offer this treatment for spasticity symptoms or spasticity-related pain. Nabiximols were considered probably effective for spasticity, pain, and urinary frequency symptoms, and probably or possibly ineffective for incontinence, spasticity signs, or tremor by the AAN. The AAN stated clinicians might offer nabiximols for the symptoms with demonstrated benefit and not offer nabiximols for treatment of tremor. So the current CRRB guidance for treatment of MS with cannabis includes 2 graded recommendations summarized at the top of this slide. These grades were made using a level of evidence criteria from the national academies. So we're all on the same page. I'll read these recommendations. So first, it was concluded that there was substantial evidence to support cannabis or cannabinoids are effective in improving patient-reported MS spasticity symptoms based on good quality findings of oral cannabinoid studies. Second, it was concluded that there is moderate evidence to support cannabis or cannabinoids are effective for neuropathic pain in MS patients. Current guidance also includes a lot of other non-graded information. I extracted some examples at the bottom of this slide. To conclude this presentation, I just offer some examples of places where the CRRB may consider edits to the guidance document based on my review. Regarding the graded conclusions, based on the evidence from Filippini et al. And other systematic reviews, it is reasonable to maintain the conclusion about cannabinoids for spasticity. For the other graded conclusion about neuropathic pain, the CRRB may consider revising the level of evidence designation based on Filippini et al.'s findings, or alternatively choose to maintain the moderate rating. The board may decide between those rating options based on their interpretation of the National Academy's evidence rating system relative to Filippini et al.'s findings. If desired, the board could consider adding graded conclusions for other MS symptoms addressed by the systematic review of cannabinoid studies, such as tremor or overactive bladder symptoms. Alternatively, non-graded information about these symptoms could be added to the guidance document. Examples of other non-graded information the CRRB may consider adding to the guidance includes more information about cognitive concerns, since there have been several recent systematic reviews with expanded information about that, and more information to guide treatment of spasticity. For example, details about the types of cannabinoid products, median THC or CBD doses from nabiximols trials, and basic characteristics of patients that were included in the spasticity trials. All right, well, thanks for listening to all that information. That concludes my presentation. These are the references for the reviews, and please let me know if you have any questions.
Thanks, Lauren. That was excellent. Well prepared. So should we open it up to discussion about those? Well, the review and or the question about graded recommendations. If you want to go, would you go back, Lauren? Can we go back to that one slide? I have a question for you. So you had the question as whether or not we should change our level of evidence for neuropathic pain, which I would say there wasn't enough convincing evidence to change it in my mind. I'd just leave it as to maintain the moderate evidence. But I have a question about the tremor and overactive bladder symptoms. If we were to add graded conclusions, what would they be? Would they be limited evidence or insufficient evidence, or what, based on your review? Because there was, like you said, I think as I recall, there was subjective improvement in tremor and overactive bladder symptoms with daytime and nocturia, but no change in incontinence episodes, the objective measures. So would that be limited evidence?
Sorry, my mute button changed locations on me while I had the slides pulled up. I mean, I think it's, up to your interpretation maybe of this bottom part for limited evidence on this slide versus no or insufficient evidence. The tremor studies, there were fewer studies compared to the overactive bladder symptoms, and for tremor, they didn't find any benefit in the short-term treatment. There was that one longer study which showed a benefit longer. I'm not sure why, that was, but based on that, what they found for tremor, I would probably personally lean towards rating it as no or insufficient evidence, because these would be like mixed findings from a small number of studies. For the overactive bladder symptoms, there were, I think, 4 different studies that assessed that. And although they didn't meet significance for their primary outcome, there were several secondary outcomes that were shown in multiple studies to have some benefits for overactive bladder symptoms. So I would personally probably lean more towards rating that as limited evidence.
That's what I thought. Yeah, and I wonder, I guess this question goes out to the board. What do people think about adding? I for one really like the levels of evidence, because it kind of gives a little bit more to think about. Like, take for instance the bladder symptoms. When I treat patients with that, it's so hard because there's so many limited options. And when I think about the studies and the limitations of the studies with the cannabinoids, it makes me think, well, they found subjective improvement in daytime voiding and nocturia episodes, but no change in incontinence, which incontinence is easier to measure. It's an objective measure, whereas daytime voiding and nocturia episodes do have some element of behavior, right? It's an urge. You can measure incontinent episodes, but you can't measure urges, like restless leg syndrome. You can measure the number of times they get up and move their legs, but you can't measure the urge or the sensation that they feel. And our medicines for restless leg syndrome reduce the sensations. And I wonder if cannabis has that effect with the daytime void and urge incontinence. Urges to void, not necessarily their incontinence episodes, because it's probably frankly not potent enough to hold it back or to strengthen muscle tone, but it might affect the urge. So that's why I wonder, would it be helpful to post as limited evidence, so it could be tried, it could be used, but recognize that it's very limited. So I'll open that up to the group. What do you think about changing the level of evidence for tremor and bladder, neurogenic bladder symptoms?
Well, I think we should update what we have. I was just looking at what it says in our current guideline, and it just has the data from 2017. So I think we should add to that document this current information and maybe change, because there are 2 bullet points. One says evidence from preclinical studies suggests that THC, CBD, and nabiximols improve MS-associated tremor, spasticity, and inflammation. That's the first bullet point. And from what she just reviewed, which was awesome, Lauren, I think we should move that tremor to the next bullet point that says limited. And there was no data in that current document about inflammation. So I think we need to remove inflammation as a indicated use, or move it to limited. I don't know if there is any data really. So I would agree with moving those things around in our document and updating what we have as a reference.
Could anyone just share the screen of the things we're comparing? I'm on my laptop. I'm trying to flip through all the different things to do side by side of what we're discussing.
I would second everything Dr. Norris just said. I think a lot of the initial evidence from our first document was impacted by preclinical studies, because that's what we had at the time. I think with this Filippini review and its randomized control trials, I think that is much better evidence of the utility for patients. And I think it warrants updating.
Excellent. I agree, Misty. So we're going back to that document, comparing those for Mike. Which one did you want to talk about, Mike? The showing the tremor in the bladder?
Yeah, I guess those ones that we were just thinking about changing there of what we say right now versus what the change would be. I know we've got Lauren's comments on the sides there.
Sorry, I'm trying to make it so you can see everything. I know it's hard. It's a little squished.
Okay, so keep scrolling down. I think you're almost there, right? Yeah, the next page right there. Those evidence from preclinical studies suggest THC and nabiximols improve MS-associated symptoms, tremor, spasticity, and inflammation. So that's the paragraph we're talking about. What both Jennifer and Misty have suggested is we break that up because we just listed tremor, spasticity, and inflammation together. And then in the next one, you have spasticity, spasms, pain, sleep, and symptoms of bladder dysfunction. So those are all kind of lumped together. And I think I agree completely with Jennifer and Misty that we reorganize that paragraph to separate it out, those symptoms. Because as you know, if you treat MS, you're treating symptoms mostly. I mean, disease modifying agents are few. But improving quality of life and treating symptoms is huge. And so I think it warrants, now that we have some, even if we list the tremor as no or inconclusive evidence, and then the bladder symptoms as limited evidence, it would really help, I think, guide some treatment decisions for clinicians. And then, of course, the spasticity, upgrade it to, what was the final grade, Lauren? Was it moderate on spasticity?
For Philippini et al. Yes.
Yeah. So the idea would be upgrade spasticity, single it out and upgrade spasticity symptoms to moderate evidence, neurogenic bladder symptoms to limited evidence, and then leave tremor. Sleep, well, sleep we've addressed elsewhere, but didn't Filipino address sleep separately as well? And sleep issues related to MS. I thought that was one of them, but maybe not.
Yes, I didn't include it as a focus because it wasn't their prioritized most important outcomes that they were looking at. But I do have oops, I can't share my screen, but I did prepare a backup slide that talks about sleep quality. They found a slight improvement in sleep quality difference on the numeric rating scale. And in patients, increased odds of patients who reported sleep improvement in nabiximols trials, Canidor, and dronabinol studies versus placebo. And this was all short term for up to 14 weeks. And they didn't rate the level of evidence for those outcomes.
Okay, well, if they didn't rate it, then maybe we should, not muddy the water with that. Leave it the way it was. But at least, as we've talked about, should we address the spasticity, bladder symptoms, and tremor, and give them, according to the document, levels of evidence in our document? Does that help, Mike?
Yeah, thanks. It was there's lots of stuff and very comprehensive. I just wanted to be able to see it in front of us when we were talking about it. So it's great.
I did want to bring up that there is a box at the top of our document, highlighted box, and it only lists 3 levels of evidence: substantial, moderate, and insufficient. So I think that box also needs to be updated.
Could I just align it with the NASM document?
Yeah, that's a good point. Just make it more consistent with that. If that's what we're using and that's what Lauren's using, then maybe we should update our box to add that other category of limited evidence.
I agree.
Make it look consistent. And then reference, is that reference that for NASM? I mean, that, did we reference that at all, or did we just make that box up? Oh, there it is. Okay.
It's referenced, yeah,
Okay, good.
but we should add this other to it, I think.
Yeah, I agree. Good point. Any other suggestions? Because this NASM this was 2017. Were these? So that was before our document anyway, but
NASM 2017 is that major report they did on cannabis where they rated the level of evidence. And it's also where we got those evidence rating categories from, like substantial, moderate. and
Good.
We also invited some QMPs that have record in our system of recommending cannabis for these types of conditions. And I didn't know if you wanted to invite, I don't know if any are on the call, if we wanted to invite any of them to speak about their thoughts.
yeah, sure. This is a great time. And now that we're pondering these changes and we've identified what changes we would make, this is a great time for discussion about, yeah, if QMPs have experience treating MS patients, and if they have any input to this discussion, that'd be great. So can we identify anyone on the call that fits that category?
You could just unmute or use a reaction. Oh, I don't see anyone. Sorry. Thought I'd try though.
Well, it's a good point. We would love to add to this discussion. MS is a very difficult thing to treat. And I think it was worthy, Lauren, as you pointed out, the difference between short-term and long-term treatment, the symptomatic treatment in the short term. A lot of these studies were not long-term. I don't know, in my experience with cannabis has been, it's helpful for a lot of symptoms, but it's not potent enough to really modify disease. After reading all your stuff yesterday, I thought, well, that'd be a trade-off. If long-term it does slow down the progression of MS somehow, do you trade that for this potential of causing long-term cognitive deficit? And which would you choose? If you were to treating a patient, do you want to slow down your MS but develop cognitive deficits in the meantime? What a conundrum. But I don't know if we'll ever know that. The limitations are so vast with, like, the AAN study talked about how it's really hard to hide the side effects from cannabis when you're comparing against placebo, especially if someone has used before. So we're not going to get great randomized evidence that without noticing or unmasking the adverse effects. So it's really hard to study. Any other discussion or experience?
Well, I mean, I'm a QMP, so I prescribe it for these purposes, and I have found it to be helpful for some people. Some people are just really intolerant of it, though. They just get super lightheaded and they already have so many issues with balance that they can't tolerate it. It's worth trying.
I saw Dr. Viner's hand. Do we want to open up to public comment now? If the board is, or
Before we do, I just want to add that there is one other review out there by Haddad et al. From 2022 that does have a little bit of different additional information on some of the adverse effects associated in MS patients that I can share with the board however he feels most appropriate. But it does a nice job of talking about more treatment-specific interactions and adverse effects in various groups of patients. So I think that warrants looking at and maybe seeing how it compares with the other reviews that Dr. Heath has presented.
That sounds great, Misty. So maybe this is the time where we give ourselves our homework. So Misty, if you wouldn't mind sharing that with the group, that would be excellent.
Great. Sarah, would it be easiest for me to send that to you?
Yeah, that's perfect. And I can distribute it to everyone.
Thank you.
Thank you.
And then if we want to move on these changes, we don't vote yet. We need to actually produce a document. And as I recall from talking previously, it's not up to, we can't just dump all this on Lauren. Lauren has done a tremendous amount of work. But we should all try to contribute to this revision. So, but I would ask Lauren, if you have a starting place, it's not your job to just write it all for us, but if you, since it's on the top of your mind, could start the edits and then send them to us, we should all try to write and contribute to the editing process so that on the next meeting we can have a document to vote on.
Yeah, and
So-
Lauren, do you have, that's a great idea. Do you have access to the document I was making notes on, Lauren?
I believe I do. I'll double check.
Okay, if we could just use that, everybody already has access to it, and then everyone can make their changes and review it there. That would be great.
Yeah, so let's try to do this via email in the next 2 months so that we don't have to do it during the next meeting, because we want to move on to a different topic, maybe the next meeting, and just vote on our changes. So watch your emails from Misty, Lauren, and then Sarah. Let's start a working chain to revise the document.
Yes, I'll make sure that all those recommendations get put in and highlighted as new changes from the document so everyone can see.
Perfect.
And
Okay.
Sarah, really quick, just to help me understand also, you sent a notification prior to this meeting to some of the medical providers that we know recommended medical cannabis to individuals with MS, right?
Yes, went through the electronic verification system and pulled up a report of people who either specialize in neurology or have made recommendations for patients with conditions that are related to this topic, and sent them a meeting invite.
Yeah, and so I wonder if we could send them a second invite, and they likely won't come because of course they've got schedules and things, but they would at least be notified and they could listen in, like they can listen into the recording of this meeting, they could listen into the next one too.
Yeah, I can send them the link to the YouTube video once we
Yeah.
publish it.
And I think they may find the handouts helpful.
Mm-hmm. Yeah, those were all attached to the meeting that I
Great.
sent out to them, but I can send them again, no problem.
Great, because if there's any input they can provide from their expertise, that would be informative as well.
Yeah, real world is always helpful.
Right.
Yeah, thanks, Sarah. I think that would be helpful, and the way you word it, could be attention grabbing, like, hey, we're updating our guidelines for, MS treatment with cannabis products, and, what desire input. And that input could be even anecdotal, because even if it's not contributing to the actual guideline revision or our document revision, for educational purposes, as we could have a different repository for information on treatment experience.
That's a great idea. I like that idea a lot.
Sarah, just through happenstance, I already sent you an email about this, but I have MS, and I could ask my doctor if she would mind attend. I don't know if she'll have time, but if she could attend the next meeting, I mean, that's all she does, is she runs an MS clinic. So
Maybe we can look at that at a different time. Next meeting, we might have to focus on a different topic.
yeah,
Yeah.
if you want to schedule something like that,
Yeah, we could probably schedule like an ad hoc or something.
Yeah.
Are available. Yeah, that would be great. Thank you so much, Molly. Thank you for sharing.
And Molly, you'd be welcome to share the handouts.
Yeah.
And she could share her input directly with Sarah. And we can incorporate as much as what that shares.
Okay, I've asked Sarah to send me the research once the committee's completed its work, and I'll just check with her, my doctor, and see if she has any comments that she wanted to add.
Okay, great. Thank you so much, Molly.
That would be awesome. Okay, do we have any other? We're going through our agenda pretty quickly, so I don't know if there's any other topics or comment. We could open it up then. I would love to hear what Dr. Viner has to say. Anything else from the board really quick?
Sarah, I just sent that to you.
Thank you.
No, I was just were there a discussion of new board members to replace Dr. Fine and Dr. Carlson, or is that?
Not yet. So we have a couple of candidates. For Dr. Carlson's position, it has to also be a person that's on the CSAC committee, and we've reached out to that individual, and they don't have the time to be on both boards. So that remains vacant at this time, but we have two names that we've sent to the UMA to get their feedback first, and then I think we're still waiting for that. Rich, have you had an update from Michelle yet?
No, but we
No.
did give her the deadline of this week.
Okay.
So we do expect to get her input by the end of this week. And that would be for a medical research professional. And the other is an input. And
A QMP.
yeah, and we can discuss those privately once we get some additional input from UMA. I think that's appropriate to vet some of those with some of the board members before we move forward. Yeah.
Okay, excellent.
And,
So,
and just one other item that I thought might be good to just share with the group before we go into comment, if it's okay, Dr. McKeith, is we have announced the members of the Medical Cannabis Policy Advisory Board. The first meeting of that board is coming up on July 18th, coming up soon. And Misty Smith is the medical research professional that's been selected to serve on that board. So congratulations to Misty. We're so grateful that you've been willing to serve on that board as well, in addition to this board. And anyway, so that gives you a little heads up about something that's related to the operations of this board. And we're excited about that new policy board. There's 9 members of that board. It'll include individuals who work in the industry, individuals who work at medical clinics, individuals who are patient advocate, medical cannabis card holding patient, and someone just from the public that's willing to serve on the board but does not have any connection or gain from decisions made by the board, and also a representative of law enforcement is going to be a member of the board. And this board is appointed by our executive director, Tracy Gruber, with nominations from the licensees, the cannabis licensees, and Utah Patients Coalition, and other groups, and Utah Medical Association, and a few others. So we're excited to have this new communication hub and recommending body for the industry to benefit from, and for lawmakers and our state agencies to benefit from.
yeah, thank you, Rich, and congratulations, Misty. I think the last 2 years have proved the need for that board, a place where people can have input that direct policy, whereas we're focused more on the treatment evidence-based guidelines and the medical part of it. So I'm glad that's progressing.
And then just another update, Sarah, would you just give an update on the Sublime study and also the Center for Cannabis Research at the University of Utah?
Yeah, so the Sublime study, The board has met once, the advisory board for that. That's the study that the legislature gave us funds for to work with the University of Utah to get the patient experience for our program. And that will be over the next 2 years, they'll be conducting that. Currently, they've just, they're completed recruitment at this time and working on creating the surveys that will be distributed to the patients. And then as far as the center at the University of Utah for medical cannabis research, Valerie, and I'm sorry, I cannot pronounce her last name, has been hired as the senior manager for the center. And she's going to give me her official bio and headshot and everything to share with you. She's just started this week at the university and is currently onboarding. And once I have more information, I'll share that with you guys.
And just the other week, both Sarah and I attended the stakeholder meeting of the Cannabis Regulators Association. And this was held in Annapolis, Maryland. And we were able to network and coordinate with other states. A lot of them obviously are focused on adult use, but some are focused on medical use like Utah. And there was in fact 2 sessions that focused specifically on medical use and research. And Sarah and I both found those sessions very helpful. Had discussions about provider training regarding medical cannabis treatment. And a lot of these organizations are wanting to require that training prior to when a provider begins to recommend to a large number of medical cannabis patients. And that's something we have in place that other states are looking more at. Also, there was a discussion about how can state regulators better facilitate medical research or research on medical cannabis. And one suggestion they had was when you're building your softwares, build software that can collect data that's accurate and it needs to be cleaned over time, such that under the correct permissions with CRRB in place and everything, that data de-identified can be shared with researchers. And so that was some good advice for us as we began a long journey of putting together a new software, trying to see the end from the beginning. And the beginning is now. So we're working with Sarah on that. Yeah.
All right. Should we get started on public comment?
Sure.
Yeah. Unless the board has any comments.
No, let's go ahead. And I think Dr. Viner's been waiting patiently, and I can't wait to hear what he has to say. So, Sarah, will you be our regulator as usual?
Hi, this is Dr. Mark Viner. I'm a psychiatrist in Nevada, but I'm also a Utah qualified medical provider and have a license in Utah. And I have no financial affiliations. Just a couple clinical aspects of the MS. I noticed the Slavin JAMA article from 2018 was not referenced. You might want to just take a look at that because he points out, even though there's sound meta-analyses, there's really limited weak trials with MS and cannabis. So you got to be cautious still. And now the other thing is, point 2 is it depends on where in the MS the patient might be. Like it's a relapsing and remitting disorder, and there's neuroinflammation and neurodegeneration. It's very fascinating. If people understand cannabis and MS, that's really comprehensive and complicated topic. So provider training is important. But anyway, the THC seems to help the spasticity because the glutamate excitement is decreased. But most of the CBD affects the activated T cells in the beginning of the infection flare up. So you might want to use CBD early, THC later. The CBG helps the microglia, another mechanism involved. So there's some new studies with CBG. So you could CBD and CBG can be useful, and even beta caryophyllene, the terpene that has CB2 agonist properties. So clinically, it really depends on where the patient is in the disease and what products you're going to use, because they could be quite useful. And then finally, you really got to watch out for drug interactions with the new MS meds, Ocrevus, CRRB. These are huge immunosuppressants. They just shut off the T cell completely. And so cannabis is also an immunosuppressant. So you really have to put a warning to clinicians about if they're currently getting MS treatment. You can't just throw in a bunch of cannabis and you'll cause severe immunosuppression perhaps, or
Thank you, Doctor.
withdrawing it. So
Right, we're at
anyway,
2 minutes. Thank you.
oh, thanks. Sorry, bye.
Is there anybody else with questions or comments?
If I can add to that, thank you, Dr. Viner. The Haddad article also talks about the combinatorial immunosuppression with some of the current medications. So that's a very, very important point. The drug interactions.
Okay, there doesn't seem to be any more public comment.
Well, so now we could have board discussion on Dr. Viner's comments. Thank you, Mark. Again, I find that very useful. I agree. I think that there's so many details that you could dive into treatment and make it more specific. I think the problem is these studies, the Philippine or the AAN, a lot of these studies, they don't differentiate between the types of MS. They're just, I think, is it, and Lauren, maybe you could comment, is this just a recruitment problem for getting patients in these studies? Because they didn't differentiate between the type of MS they have. They didn't differentiate between, types of, the age was 18 to 60, and it's, if they were a previous user or not, and the tolerance. I mean, there's so many variables that well, they mention, but they don't select out, because I just wonder if they're just limited on their power of study. Is that accurate to some degree, do you think?
Honestly, I'm not sure. For the sake of time, I focused on reading the systematic reviews. So I was mostly limited to what they were saying about the original trials, and they don't really go into, issues with recruitment or getting sufficient power. So I'm not sure. Maybe they were just trying to keep the study potentially generalizable to patients with all types of MS. And I do know that there were some differences in the patients that ended up getting recruited for some of the trials, like for the spasticity trials that were included by Filippini et al. A high proportion of the patients in those trials had the primary progressive or secondary progressive MS compared to the relapsing remitting form of MS.
Yeah. Well, thank you. I think these are good things to consider. I always think about that when I read these studies, because there's so many limitations to them. And I think, well, maybe they just don't have the number of people to differentiate out, because it would be nice to get that specific with these studies. But I think for the purposes of our revision of our guidelines, maybe we should add some language about immunosuppression and drug-drug interactions. I think that's useful.
I was just going to ask that if we wanted to focus on adding a section for that.
So let's put that in the minutes. So as we work the next 2 months on that document, find a place for those kind of MS specific precautions. We could just generalize and say that, and then list under them the type of MS, drug interactions of MS treatments, and then the potential for immunosuppression. Or phase of disease. That's getting even more specific. But any other comments? Well, this is easy. This has been a fast meeting. I didn't expect it to go this fast. We've had a lot longer meetings than this.
You've done a great job directing us and keeping us on topic, so good job.
I think Dr. Heath deserves credit too for such a
Yes.
comprehensive and high quality review of the clinical literature.
Yeah, it was clear and concise.
Thank you, Lauren.
Thank you all. Glad to help.
Awesome. Well, just a few more business items that are just meeting items. I think we discussed, was it at the last meeting or during executive meeting, and wondering if we change the cadence of this meeting. I love how we can be more productive, but perhaps not, but perhaps doing a meeting every other month. Did we discuss that at the last meeting?
So we had sent out a Google form, and I'm not sure if everybody had a chance to respond with what their preferences were. I can send it out again for everyone to see if it's every other month or every quarter is how we wanted to meet. So I'll send that back out.
That would be great.
Sure we have everybody's feedback.
Yeah, the proposal is, do we change the cadence of the meeting to be a little bit less frequent so that we could make them, well, give more time to do our homework and, make them very productive like this one. Plus, we have busy schedules and we want to do high quality work. It takes time to review the research, to prepare these presentations, and then make our revisions. So please answer that survey about the meeting schedule. And then we'll talk about the content of the meetings and make a plan. I'd love to have at least a 6-month plan of what the content will be. Also, if we have guest speakers, like I would love to have some neurologists with experience in treating MS to weigh in on some of these topics, or whatever topic we're addressing. And so having a longer time between meetings would allow for more preparation. So that's the idea.
Matt, if I can make one more recommendation, I think it'd be valuable on each of our literature reviews and our recommendations that we make if we just standardly have a section of it dedicated to safety, potential for drug interactions, clinical concerns, et cetera. I think that is going to be highly valuable coming from us and from the literature, what's known, or at least what could be predicted.
Sounds good. Sounds good to me, because that's part of our role, right? We want to search for efficacy and evidence-based use, but also we're the ones that's supposed to be organize the warnings and the pitfalls, right? So
Efficacy is important, but safety is equally important.
that's right. It's just as equal. Yep. So having that as a regularly scheduled, yeah, that's fine with me. That sounds great.
Before we end, Matt, do you mind if I just give an idea of one of the agenda items that'll be on the policy advisory board?
Well, that's great. I was just about to say, now that we have these other entities functioning, the advisory board and the Sublime study, a certain amount of collaboration, or at least knowing what the other side is working on, would be great. So maybe we make that a regular agenda item as well. Just like we have the updates from the legislature every spring.
Sure.
Yeah, I can do the updates on those since I'm the one that's working.
That'd be great. So that we just
okay.
tabs. Yeah. Go ahead,
Okay.
Rich.
Yeah. So one item that'll be on the July 18th Medical Cannabis Policy Board meeting agenda is that both the Department of Agriculture and Food and DHHS have gotten some input from representatives of the industry about adding a requirement that when it's a gummy or a lozenge or a you know, a gummy, they always have to be in squares. They can't be in circles. Those edible type products, whenever they have those, to have the dose unit per piece of the milligram of CBD and THC listed. Not right now, all that is required is that there be the number, the milligram per package,
Which is
right?
annoying, I think.
Yeah, and so we felt like it made sense for Department of Agriculture and Food to amend their processing rule to require that when a particular product is a gummy, to require that milligram per piece dose unit. So that would enable a medical provider or a patient to be able to see on the packaging and online. So if they're ordering online, they'd be able to see online what that is per piece of CBD milligram or THC milligram. And also, not just for gummies, but you think about other types of concentrates like a liquid suspension, right? Giving some flexibility to the processor to decide, you know, what the dose unit is, but they would declare, here's the dose unit, you know, whether it's 10 milligram or whatever, and here's how much THC and CBD is in every dose unit. And the volume of doses and the size of the dose is different according to every patient, right? But the processor would need to just make choose how they're going to define their dose unit for that particular concentrate. And then, you know, when it's a liquid, and then they would have that appear on the packaging. And one of the concerns is, well, how do we fit this along with everything else that regulators require that we add, right? Well, they need to figure it out, that they have room for their logos, they have room for these other items. And so the thought is, this is patient safety, this is provider, a tool that providers use, a tool that parents use and patients, that is very critical as they make decisions about how much to consume. So anyway, when it relates to vaping cartridges, though, it gets a little more complicated because of the differences in the types of devices that are used, right? Because it's the mechanism being used to administer the product is this device, and how much you get out of each draw or puff or whatever could you know, depend on what device you have.
Well,
Yeah.
and how long you inhale, how long, yeah,
Right.
there's all kinds of
Yeah.
very
So
variables
that's a
there.
little trickier. But on the 18th, we put together a handout that we're finalizing. We're getting input from the industry about it. We've already gotten some input. And this would be a requirement that we give some time to the industry to respond to. It would be a Department of Agriculture requirement. So it wouldn't be you have to do it tomorrow. A lot of them already do it. But we noticed that not all of them do it, and that it's not a requirement. It's a best practice, it's just not a requirement. And the ASTM, the National Standards Organization, it's one of the standards that they have put forth, and they're recommending it to regulators across the United States. And some regulators require it and others don't. We found it's kind of a patchwork across the United States, but it just seems, especially for medical use, that there be that in place. But for all use, it seems reasonable, but especially for medical use. So we'll keep the board informed as to what happens with that. And it'll be Department of Agriculture that will make the final decision about exactly what that language will be like and the extent of the requirement, but that's the concept. That's all.
Well, thank you. I think that's really important because I've had many patients confused about their dosing And it was annoying that it wasn't listed per dose. It was just a total amount, and that's very confusing. So I hope they really move with that, because that just makes sense. You need to know your dose unit in order to make clinical decisions. So
Right.
All right, thanks, everyone. Looks like we're at the end of our agenda. Do we have a motion?
And I guess one thought is when we want to have our next meeting. We want to do that in August, Sarah, in
No, not in August. That's too close. We're gonna get the feedback from the board,
oh, okay.
and then determine that.
Yeah, potentially September or,
Mhm.
okay.
Yeah, thank you.
I'll make a motion to adjourn. Thank you.
I'll
Yeah.
second that.
we have a motion and a second. All in favor of adjourning? All right, it looks like we at least have a majority there. Thanks, everyone, so much for the meeting, and watch your emails, and we'll see you next time.
Right. Thanks for stepping up, Matt and Mike. Take care.